Now I would like to go to the second part of my talk, which will be a little bit more focusing on the clinical implications, which starts with the question, why is PET more sensitive than other techniques, and is that superior sensitivity of any relevance? Because now we talk about the clinical relevance of all of this. And to start with, I would like to show this meta-analysis. When I started working in nuclear cardiology about 17 years ago, I was fascinated by hibernating myocardium, and I thought, wow, if a patient has hibernating myocardium, he is doing better. Now, the big deception came with this meta-analysis here, and many others were following, showing here the patients with viability and those without viability, and then those were conservatively and those were invasively and revascularized, and here the same two groups. What we figured out was that we had a similar event rate in these three groups, but in those patients with hibernating myocardium who had conservative treatment, we had the highest event rate. We realized that something in our understanding was probably not as it was in nature. So hibernating myocardium is dangerous. And many other meta-analyses which we're following always showed that if you do have viable tissue, but you're going to treat it with medication only, then you have the highest event rate. Even in our Zurich registry, where we collected over about 10 years or so our patients, when we started the program, we had those with and those without hibernation, we had those with and without revascularization. The ejection fraction was rather homogeneously very low, and many of them had triple vessel disease, and the mean follow-up was 4.5 years. And if you look at the survival curves, you will see that those with viable tissue but no revascularization had by far the worst outcome. If we look this way, we saw that again this bar here was the highest, and we had a 38% decrease in annual death in the revascularization group. Whether that is due to revascularization alone or whether this is due to other factors is difficult to say, but this is about what you get with the optimal medical treatment of heart failure, modern heart failure treatment. You reduce mortality by about 38%. So that's what you can get with revascularization, just like this, while here there is no big difference. There was this other study with about 3,000 patients, obviously from the US, a large database. They found a very similar result. The medical treatment group had a very poor outcome and a very high death rate compared to the others. The interesting part is it seems that viable tissue is a risk factor because a lack of revascularization is associated with increased mortality. Even in those patients where the contractility will not improve that much, that their function improves. And that's what I would like to show you in this slide, which I think is quite important. So this part of the benefit is the improvement in LV function. That's a part of the success. But the biggest part of the success we get because we reduce the vulnerable substrate. It means if you have some viable tissue and you don't do anything, this can be a focus of arrhythmia and kill the patient. If you revascularize, eventually the function will not improve, but the outcome will, because you don't have this vulnerable substrate. That's why it will be important, even in patients with a little bit of viable tissue, that you will recognize it and eventually treat the patient. PET is more sensitive because we have a metabolic reserve. We don't need a contractility reserve, we just need metabolic reserve. And the sensitivity, which is superior, has a clinical relevance, because if you detect this, you will select those patients who are at highest risk for future treatment strategies. And at the moment, we have now shifted away from saying only transplant versus rest. We have a third option, and that's implantable cardioverter defibrillators. There is now trials going on to see whether we can nicely identify patients with the FDG scan to see whether they benefit in terms of their survival from the ICD, because as you probably know, ICDs are very expensive, and maybe 5% of patients have a discharge over the next year, so 90% or so never get a benefit. That means that we have not selected the patients really very strictly, and probably a test like this will be helpful. In fact, we have some data indicating that hibernating myocardium is not just statistically found to be vulnerable, but they also found that the beta receptors are different. First of all, we have a reduced presynaptic reuptake of the hydroxyephedrine, the C11 in pigs, which shows that we have more catecholamines active there, and that's why our beta receptors are decreased. And also, not only they are decreased, which reduces our protection of the heart, but they also shift to a low affinity beta receptor form. So you have a polymorphism and the beta receptors change. And this all makes the heart more vulnerable and more prone to this kind of arrhythmia because it can serve as a focus. The beta receptors are functionally gone, and so it hits the myocardium and they have an arrhythmia, and this causes the sudden cardiac death. And we can identify them by showing that they have hibernating myocardium. And so there is now the fourth option, not just distinguishing scar from viable and say, here we revascularize, here we do transplant or medication. There is another option now. If we have limited viability, what we call, we're not expecting that ejection fraction improves a lot, but we can resynchronize the patient and put an ICD because we know that he has a vulnerable substrate. We do have these kind of patients. Very often, the first step that I mentioned you in the algorithm, the anatomy, is preventing us from offering revascularization. Some patients simply have non-revascularizable arteries. This patient, for example, had a circumflex artery which was totally occluded. And in this technetium tetraphosphamine SPECT CT hybrid picture, you see a very large perfusion abnormality. If I call it scar, then some of my cardiovascular surgeon colleagues phones me up and tells me, well, if you call it viable, then because I see some FDG, is it now a scar or not? So I call this perfusion abnormality. It's a perfusion decrease, perfusion defect, and the FDG. If you look here with the FDG, I do have islands of viable tissue within this territory, which has an almost occluded circumflex or occluded circumflex and very poor flow. We have preserved, but not transmural preserved, but preserved islands of viable tissue. This patient will get arrhythmia and can die from sudden cardiac death, and this patient therefore got an ICD. Certainly, before we implant these very expensive devices, it would be advisable to have a quick look with any of these techniques, perfusion or particularly viability scanning, to see whether we do have a contact into scar or rather into viable tissue. I think it would be nice to know this before we implant an expensive device, and in the future this will be done more and more. So this is certainly a modern, important future application of FDG scanning, and if you want to know the whole anatomy, a PET-CT can be helpful here. I would like to show you here some of the cases. As recommended and as mentioned before, we would like to have ammonia rest and ammonia stress and also FDG. So it means we would like to have a PET perfusion if we do PET FDG. However, there are some logistic issues. If you use ammonia, you use a cyclotron. If you use rubidium, you have a generator, and probably it is less of an issue. But the problem is that FDG has a half-life of 2 hours, and this has 10 minutes. Rubidium has 80 seconds. The issue is, which tracer do I want to use in which sequence? We produce FDG in the morning, and I would like to use it as long as I have it. So I would not like to do an ammonia scan in between, during which the FDG decays, and then at the end of my ammonia scan, I take the rest of FDG that I still have. So I would like to do the FDG first, but then I have to wait 5 half-lives, which means I start at 8 o'clock in the morning with the FDG, and then patient stays there the whole day, gets bored, and then I do ammonia in the evening, and then eventually the cyclotron fails to produce ammonia, and I tell him goodbye, come back tomorrow, and he tells me, okay, it will be snowing, and like now we have a heavy snowstorm in Zurich. He said, tomorrow I cannot come because there is snow in the streets. So this is not a good service, and it's a real concern. If you have a rubidium generator, maybe you have less of concerns because it's so quick that you do a quick rubidium scan and then you go on with the FDG. But I don't know actually the best combination. We used to do ammonia in the morning before we had the FDG, but now we start producing FDG at 3 o'clock in the morning, so I cannot do ammonia even earlier. So these are logistic issues, and that's the reason why very often we now do a technetium scanning, and after that we just go to FDG, which is suboptimal but still works very well. What I would like to show you here is the issue of perfusion abnormality and preserved viability. Many centers use technetium tracers, and say, well, we give them nitrates and sublingual nitrate, and then this increases the resting flow, and with this I can depict most of the preserved viability because the integrity of the cells allows to take up tracer, of course. That's how the tracers work, the technetium tracers. However, if you have very low flow and you have a perfusion tracer, a classic one like technetium tetraphosphamine or maybe or whatever, the first pass will not get there if you have a very tight lesion. And that's why I don't think that technetium tracers are optimal for viability assessment. In case of homogeneous uptake of your technetium tracer, you can certainly state that this is viable because it takes up tracer, it must have cell membrane integrity which is intact, of course. But that's not the issue. The issue starts when I do have a perfusion abnormality and a hypokinesia. Then I would like to know whether the cells are viable. And here, with that strategy showing that an excellent perfusion tracer shows a defect, and they would say, well, all the rest is viable, but probably here not. On top, I do have ischemia, but I would like to see whether I do have viable tissue in the apex, and in fact, with FDG, I can prove this. Now, in this case, you could argue that you have an ischemia, which is probably a little bit, just about a bit more than 10%, it would justify revascularization. But this is a proof, of the concept that perfusion tracers are perfusion tracers, and they reflect perfusion. And if perfusion is very poor in a certain segment, it's not reflecting metabolism anymore. And that is, I believe, quite dangerous that we mix up the two of them. That's why we always do both. This is another patient where we do the almost classic protocol now in our institution. We do perfusion with technetium tetraphosphamine. And as you can see, there is at rest hypoperfused segments in the apex and the septum, and also hypokinesia there. If I look at the FDG, there is a wrong way to look at it and there is a good way to look at it. This is the wrong way here. I have put the 3 territories, and as an average in this probably LID territory, I have more than 50% uptake, but that's the average because most of it looks a bit normal, and then there is certain areas which are decreased. I don't think that looking at the whole territory is really helpful. We should look in the area of this hypokinetic scar by taking a 17 or 20 segment model approach, so that we will be able to say, okay, there are some segments which are partially viable and some are just at the edge of it, and it's not 56% average where everything is normal. It's just important here to look at the different segments. Here, very similar, and very often we have this constellation that we have a perfusion abnormality and the hypokinetic scar. That would be, the classic scintigraphic scar would be this, and here we have some reduction in viability by FDG. If you take the whole, territory, then you're just not sure that this would be wrong to take this number as a measure of viability. You should go for the segments where we have a non-viable apex and then some partially viable segments. Now, I would like to draw your attention to this case. This was an 80-year-old lady. She came with an acute myocardial infarction to our catheter, and she had, as you may remember from the anatomy of the coronaries, she has an occluded LID. They couldn't see the LID, and they told me this patient will be treated conservatively because the artery cannot be seen because it's occluded. We cannot reopen it. And one of the guys said, well, okay, but I have been working in the CT department. Let's do a coronary CT angiography. And to our surprise, they found that the LID was not occluded. It had double ostia, and it has a very tight lesion here, subtotal LID stenosis. And that's why in the CAT, the condus material doesn't go through there very easily, while if you mix it intravenously in your arm, then it goes, even a drop which goes through the lesion has condus material. And so we did a nuclear scanning also. This is technetium tetraphosphamine at rest and stress. It's almost congruent hypokinesia. This is an interesting picture here. It's a hybrid picture, but it's a single modality hybrid. It's just CT with condus material. Many people now look at the CT perfusion. I would rather call it CT blood pool. It's not perfusion because it's one time point. This is just blood pool. Here the blood pool is very low because there is a very tight lesion. It matches the underperfusion here. We have been looking at the viability, of course, because I thought, well, let's have a look at it. It's such a large defect and it would have a great impact. And it was viable, all FDG uptaking. So we resent the patient to the CAT. Unfortunately, they couldn't see the artery again. Also, they knew that there were double ostia. Second look, they say we confirm that the artery is occluded, which is of course the greatest nonsense that I have been reading. That's why I kept the case and presented here. Well, we presented to the surgeon the situation, telling him blood pool decreased, tight lesion, not totally occluded, and hypokinesia and FTG taking up. And the surgeon told me, okay, I'll put a minimal invasive bypass on the LAD, and as you can see here with this LAD midcap, very successfully the perfusion was restored. You see here the bypass here, the internal mammalian artery, and the blood pool was restored and the ejection fraction was perfectly restored, and the outcome of this patient was dramatically improved by this maneuver. So this is just integrated hybrid imaging, integrated with the clinical information. I think it has provided excellent data to show that this is a valuable technique. It has been published last 2 weeks ago in the March issue of the European Heart Journal, because cardiologists have recognized that it's important. I think that's one of the key points also. It's nice for us to produce pictures, you know, for the pictures it is nice, it is important that they look nice, but it is even nicer that the pictures are important and that they guide the treatment strategy. To this aim, I would like to show you another case. A 35-year-old male patient who had a type 8 dissection of the aorta came to the emergency surgery and was safe. And 3 months later, however, he had a severe aortic regurgitation and mediastinal infection. And so they faced a very difficult situation with necrotic tissue. And so they couldn't reimplant the coronaries in that necrotic tissue, and they had to technically ligate all the arteries and put a bypass. And this is a 35-year-old male here without coronary artery disease, but he ends up having a graft, a venous graft from the trunk up here. Very unusual situation, of course, and then a jump to the right coronary artery and the vein to the LAD up here. So this is a very complex situation. Looked fine, but the patient, one year later, came to me with minimal chest pain. But we have to realize that due to his aortic dissection and his graft that he got, he's almost 100% denervated his heart. So he will probably not feel chest pain even if he has ischemia. And he had a decreased exercise tolerance at his young age, and he was referred for the evaluation. I would like to show you the CT on the left side of the starting point, 2011, and then 2012 when he came. What you can see here is the vein is occluded, the venous bypass graft is occluded. And even more worrying is that the single artery which is serving the whole heart is obstructed here. It seems that there has been a hematoma or something, internal bleeding, which has compressed this single bypass from which the whole heart is being served. So we did a perfusion test with PET, and we found, to our surprise, that there is a lateral perfusion, an underperfusion here. No atherosclerosis, of course, at his age, and it appeared that during surgery they must have induced a myocardial infarction. It was very important for us to see whether that was viable, and so we did a hybrid picture with the stress ammonia and one with the FTG picture, and it was almost identical. So he has a scar which is non-viable, although the arteries are open. But we assume that when they put the clips here for some time, they have occluded this artery, and therefore the patient has produced a scar. Now, where is the ischemia now? And of course here PET quantification comes in, because with the SPECT, imagine you have a patient with an anatomy of one coronary artery. You induce a stress. You cannot induce a flow heterogeneity because it's one artery serving the whole heart. And so we did a PET quantification of the data that we had, and we realized that he had a flow reserve of 1.3, which indicates, of course, global ischemia due to the stenosed bypass graft, which now serves the whole heart. And 4 days later, he then underwent successful stenting of the bypass graft. The surgeon was desperate. He wouldn't touch the heart, and we told the patient that if that maneuver goes wrong, that it would be really dramatic. And so the day before he got the stent, he got married, and everything went well. His flow reserve increased. As you can see, the bars, if you look at the bars down here, we were below the magic area of 2 to 2.5, and after the maneuver, it all increased over 2. So he's certainly doing much better now. Here is another young patient, just to document that we're not just talking about the very elder part of the population. Of course, those are the majority because they have atherosclerosis and stenotic coronary artery disease, but there are also young patients like this one here, 11-year-old girl who had a surgically corrected transposition of the great arteries. So just after her birth, they had to exchange the trunk and the aorta, and of course they had to exchange the coronaries. They had to cut them out and reimplant them in the corrected great arteries. And now she was 11 years old and complained about chest pain. Now normally with a girl at 11 we would not care too much about a little bit of chest pain, and we would care, but we wouldn't think of coronary complications. But here we know that sometimes the implantation site can have some kind of stenosis because there is tissue which is alterating after the scar is building. And so the girl, before she came to us, had an angiogram, an invasive angiogram, and that was normal. So they were desperate, and in the early 90s when I started my PET program, it was very unusual to do a PET scan in a child, and we were discussing ethically, well, what do I have to do? What is your question? What are you expecting? And we decided to do the full program, including FDG, which was a big decision because we were not sure what we were facing. And I would like to take you through the pictures here. This was the rest perfusion image, which showed that we have here a little bit, we have, I think I have mixed up, this is the FDG down here, as you can see here. I hope you can read it. This is the FDG. This is rest perfusion and stress perfusion. You can see at rest there is already an abnormality in the anterolateral wall, which is dramatically getting worse at stress. But if you look at the FDG, there is just the inverse picture of what you see here and here. So I went back to the pediatric cardiologists and told them there must be something with the left stem, with the left main stem, because there is underperfusion at rest, even worse at stress, and there is good FDG uptake. So they went back to the angio, looked at it and realized that it was a granuloma, which was going into the main stem in the ostium of the left main all the time, and there was a systolic action, and the blood flow would push this granuloma into the left main. And they went with a catheter and took it out. And they sent back the patient to us, and we could see that flow was homogeneous now at rest, homogeneous at stress, and FDG also was homogeneous. So certainly this was very important for the treatment strategy of that patient. She's doing well now, 12 years later, and has no symptoms anymore. This is another patient who had an inferior infralateral ischemia. You can see that there is a worsening of the hyperperfusion at stress, and if you look here, you see also that there is some fixed part of the scar, and if you look at the FDG, we see that there is preserved uptake. You can see that the blood pool here, not so nicely, has a lot of activity. That's a type 2 diabetes patient. We could still make pictures and still make a diagnosis, but sometimes it's even worse than this, and sometimes we really have a problem. Sometimes it's not as nice as in these cases that I show you here. I just go through here, and that's why I would like to show you this trial. There is one trial only. There are different methods to look for viability, and all these are reimbursed in my country. FDG PET is not reimbursed, but the only study showing that in a prospective randomized trial, invasive and non-invasive assessment of viability improves the patient's outcome was done with FDG PET. That's the only test which is not paid in my country. But this trial here is a prospective randomized trial that put the patient on a PET arm and on a non-PET arm to see whether they're doing better. So they stratify the patient, and then they randomize them to a standard therapy and to a PET-guided therapy. The standard is very interesting. It's just clinical judgment. That's, eminence-based medicine. They just do what they think is best. Here they do a PET-guided therapy, and then they follow up the patients. And interestingly, the question was, do we have an impact on outcome? And if you look at the numbers here, you would say, well, the standard arm does worse than the PET arm, but it's not significant. So we don't have an impact on outcome. The problem is that not all the doctors who got the results from the PET did act upon that. And so if you look at the adherence, the adherence was only 65% in the moderate viability and just not even 85% in the high viability, large viability patients. So this is quite interesting. We have to teach them better. If you take those patients who were adhered to the PET findings, and then you look how their outcome was, then you can clearly see that those who went into the PET arm had a better outcome if they treated them upon the finding. But if they don't believe in FDG, then of course you don't get the benefit because they didn't revascularize the patient. So we should improve our reporting to convince the clinicians that the finding is important. And one way to improve it is potentially to have nice pictures. If we provide 3D volume-bended pictures with the CT showing where we have occluded arteries, this is the CT, and this, by the way, is the invasive angio, which is showing a congruent finding. I think this is a way of improving our reporting and of providing attractive pictures and to convince the clinician to do this. Now, how much myocardium do I need, which is hibernating, to justify this? And it turned out that 7% is enough. 7% is the cutoff. If you have a mismatch of 7%, this justifies revascularization. I think that's the important number as a take-home message. If you will start doing FDG in all the many PET centers that you have and in all the nuclear departments, I'm impressed, by the way, by the number of nuclear departments you have. You have more than the whole Switzerland in your city here. Now the techniques, just to summarize the techniques for the detection of viability, is flow metabolism mismatch or cell membrane integrity with technetium or wall motion and contractile function. If we do that with PET, we should do flow with PET as well. Of course, we could do rubidium and ammonia, and I admit that we are doing non-PET perfusion. The metabolism should be glucose because that's the most feasible. The other would be ideal, but not so much feasible. BMIPP, I have very little experience. I have some nice pictures, but we use FDG. What is the sensitivity and specificity after 332 prospective patients in 11 studies? Not so big numbers, but it's around 88% and specificity about 75% or so. These are the numbers that we have to keep in mind just to be able to tell our clinicians in which area we are. This is the imaging parameters of viability that I have just mentioned between viable and non-viable. It's a continuum. Don't believe that you can say this is non-viable, this is viable. It's of course a continuum, and we have to produce thresholds to say more than 50% FDG uptake, more than 7% hibernation. This justifies revascularization. We can go from residual perfusion over apoptosis and somewhere in between, and you always see PET here, and you could do MR spectroscopy and things like that, fancy things. PET is the gold standard. Now, coming back to the comparison of MR and PET, because I'm always being asked about this, and I can tell you that 10 years ago we were working on this. I'm running the MR cardiac imaging as well. I have no personal preference towards the one or the other. MR has no problem with type 2 diabetes. That's a big advantage. MR looks at scar, and FDG looks at viable tissue. Now, this is the curve that we obtained from our patients, and the interesting thing is you need a certain uptake, more than 50% of FDG. You need a wall thickness, non-scar wall thickness of more than 4.5 millimeters to make sure that this is viable, to predict that it will recover. Interestingly, and obviously, the functional recovery was biggest, 85%, in those who have positive FDG, positive MR. And of course, those who have negative FDG and negative MR, they have the lowest recovery rate. That makes sense. So this is, the good and the bad, but there is also the ugly. And the ugly ones are the ones where we have positive FDG but negative MR. 36% still recover. Surprisingly, however, if FDG is negative and MR is positive, only 23% recover. That's not a big surprise because MR is focusing on the scar tissue and FDG on the viable tissue. So this shows me that there might be a little bit of an advantage for FDG. However, if you take into account that maybe 8 or 10% or more with type 2 diabetes, you don't get nice pictures, this will level out, and at the end you will come up with a comparable performance of the tests. Now, therefore, maybe combining the two techniques, like this picture which I got from Markus Schweiger from Munich, showing, similar to what we saw from Michael, MR and FDG, that could be the future. However, we don't need that in one scanner. I can easily even mentally integrate this at best with the software, but certainly for this clinical application, I don't need a hybrid scanner. These are nice pictures that we can get from these hybrid scanners, also from Markus Schweiger. I'm not convinced yet that I need this to have a perfect match, because we match SPECT and PET and everything just by putting one over the other. Now, in conclusion, glucose metabolism for viability is and has remained the gold standard. It is based on increased preserved uptake of FDG in areas with reduced perfusion, and we need a flow metabolism mismatch in non-contracting or under-contracting segments. And this, I think, is my final statement on FDG. I believe that it's an excellent technique, but we have to keep in mind that there are other techniques and how well they also perform, and that they might be complementary. if I have no FDG uptake, but I have some tissue in the MR, I have to consider what the reasons are and how I can combine this. But probably I do not need a PET MR for this. Thank you very much for your attention.